Good morning and welcome to today's evidence-based health policy project capital briefing titled The Other Half of Health, an Introduction to Social Determinants. I'm Sam Austin. I'm the EBHPP project director. Thanks to all of you for joining us for the first in a six-part series of programs that will dive into the social determinants of health that will hold over the next 2 years. As you can tell, there's large interest in diving deeper into these issues, and I'm really excited to have our two speakers today, Lonnie Berger, who's the director of the Uw-Madison's Institute for Research on Poverty, and Gina Green-Harris, who's the director of the Center for Community Engagement and Health Partnerships with UW School of Medicine and Public Health. A couple great presentations lined up, looking at family well-being, community-based programs to support family and social cohesion, and specific and considerations for policymakers. And given the number of hats they both wear, this is like the only hour and 15 minutes, I think, that we can get both in the room till like 2019. So we're really excited to have both of them here today. Before we get started, I'd like to briefly introduce the Evidence-Based Health Policy Project. The goal of this project is to connect research and expertise at the university and elsewhere into the health policymaking process here at the Capitol, and to support an evidence-informed approach to decision-making through public briefings like this, regional conversations held across the state, and training sessions for legislators and staff on specific resources for evidence. This project is driven by the idea, based on the Wisconsin idea, that ongoing dialogue and the development of trust between policymakers and academic researchers can enhance the work of both. We work to serve as a resource at the Capitol and a resource on campus through nonpartisan events such as this one and facilitating interaction and mutual learning where possible. This project is a unique partnership of the Uw-Madison's Population Health Institute, where I work, the La Follette School of Public Affairs, also at Uw-Madison, and the Wisconsin Legislative Council, the nonpartisan legal staff for the legislature. I'd like to recognize Hillary Shager from the La Follette School, as well as Steve McCarthy from the Ledge Council, who are both here today. And thanks also to Stephanie Marburger, our project assistant, who makes sure everything runs smoothly. I'd also like to recognize the Institute for Research on Poverty for their, or IRP, for their cooperation in planning and executing this series. Their work in advancing the understanding and causes of poverty in the United States makes them a natural partner in this, and we look forward to drawing on their expertise of their faculty affiliates. So thanks to Dr. Berger, as well as Jennifer Noyes, who's no longer with IRP, and Dave Chancellor, who is in attendance today, and were huge helps as this project took shape. The EBHPP is made possible by the support of our funders, which include the Wisconsin Partnership Program at the UW School of Medicine and Public Health, the Community Academic Partnerships Core at the Institute for Clinical and Translational Research at UW, also known as ICTRCAP, and the UW-Madison Chancellor's Office. We thank them for their support in enabling us to hold programs like this that are free and open to the public, and supporting our work to connect research into the policymaking process. We develop these events with input from our Legislative Advisory Board, a bipartisan group of legislators that includes with a broad perspective on health issues. This membership includes Representative Jessie Rodriguez, who is with us today, as well as Representatives Joe Sanfilippo, Daniel Reamer, Joan Ballweg, Deborah Kolsty, and Paul Tittle, and Senators Devin Lemieux, Mark Miller, and Leah Vukmir. I see Senator Miller is here as well today. We truly appreciate their engagement, as well as all the legislative staff who are in attendance today, so thank you. This series grew out of discussions between our office and legislative staff regarding this framework of population health, which is developed by colleagues of mine and refined over the years by colleagues of mine at the UW Population Health Institute. You can see how health factors and policies and programs feed into the health outcomes of individuals and communities. And though the percentages assigned to each of these factors may be up for debate, the model provides a really nice framework for thinking about how a community's health is determined and what drives health. Obviously, clinical care and health behaviors play a large role, but also where we live, work, and play also drives what makes communities healthy. In this framework, these are called the social determinants of health and include education, employment, income, family and social support, community safety, air and water quality, and housing and transit. The goal of this series is to dive into each of these factors a little more deeply, to take a look at what the landscape looks like in Wisconsin and provide some takeaways for policymakers. We're starting today with family and social support, and look forward to today's presentations on how how that factor affects emotional well-being as well as physical health, and how that will affect health of communities and individuals across the life course. Part of the equation that gets us to good health outcomes is strong public policy, and the front lines of building that policy framework is the state legislature. So for that reason, I'm really excited to welcome Representative Jessie Rodriguez, who's the chair of the Assembly Committee on Family Law, for some opening remarks and her perspective on her committee's work and the interaction of family and social support as she sees it in her district. A graduate of Marquette University, Representative Rodriguez was elected to represent the state's 21st Assembly District in 2013, following work that included a time as outreach coordinator for Hispanics for School Choice. In addition to her role as chair of the Committee on Family Law, she serves on the Assembly Education and Energy Committees, as well as on the Speaker's Task Force for Foster Care. She lives in Oak Creek with her husband Aaron and her son Noah, who just started second grade, I believe.
Yeah.
So Representative, thank you for your participation today and your engagement in this broader discussion. Please help me welcome Representative Jessie Rodriguez.
Well, thank you, Sam, and I want to thank all of you who have come today. It looks like it's a pretty full room, and I'm glad to see the amount of people that have showed up to this presentation. You know, when it comes to discussing families and social support, it's an issue that certainly we hear and we discuss a lot about here in our Capitol building. When we talk about, you know, poverty, when we talk about homelessness, when we talk about the legal system. And one area that I want to talk about today is foster care. So I'm glad to have the opportunity to be able to have just a little bit of information on what we're doing on the foster care task force, but I also want to thank our speakers today and look forward to hearing the research that you're going to provide for us that would help address some of the concerns that we're hearing here in the Capitol building. This year, the speaker boss, he assembled the speaker's task force on foster care, and I happen to be one of the members of that task force. It's an area that I think it's very important that we look at, seeing that we've been hearing that a lot of kids are entering into the foster care at higher rates than we've seen in previous years. And so our goal for the committee, who is being chaired by Representative Pat Snyder from Wausau and Representative Steve Doyle from La Crosse, is to find out what's going on throughout our state, what areas that we need to focus on, and see if we can find solutions to help with the foster care system. So we did 6 hearings throughout the state, and our goal was to hear from different organizations and foster parents, and also foster kids, now adults who were at one time in the foster system, and just hear their perspective on what we need to do and what we need to change. Based on all the hearings, we've kind of settled on 4 areas that we're seeing that were coming up as issues that we needed to address. And one of them was prevention and supporting families. So when we were out, we were talking to a lot of the health services departments, a lot of organizations that are involved in providing support for parents. 2 counties that came up that seemed to have a great program, they were Marathon County and Kenosha County, and they talked about, you know, being able to identify families who were in crisis, families that were not in the foster care system, but maybe were really struggling and could potentially, you know, find themselves in the foster care system. So what they do is identify those families, and they go and do more home visits with them, find out what it is that, you know, that the services that they may need, and try to connect them to the services, thereby, you know, helping them and hopefully preventing them having to, you know, go into the foster care system. The other area that we saw that we needed to address is support for foster kids. So we have a lot of kids who are aging out of the system. It's unfortunate that we have that happening in our state, and also a lot of kids who are being moved from one school to another, interruptions in their education because, you know, maybe, you know, they ended up at a foster home, mom is better, they go back home, but mom is really not as good as she needs to be, and they go back into the system again. And that, you know, that basically causes those children to move from one school district to another, and their education is affected by that. How can a kid potentially, do well if they're moved from one school to another, not learning everything that they need? And as we know, some of the school districts have different requirements too. So we're looking to see if we can find ways to solve that. The other concern for foster kids is that, there's 84, they did a study, and 84% of foster kids say they want to go to college. Only 20% of those that graduate high school end up going to college. And of those that do go to college, only 2 to 9% of those end up graduating college. I mean, that's pretty staggering. And we had some kids who were in the foster system who are now adults, testify and say, I didn't know that I needed all these services. We had one, Jamila Love, I think a lot of people know her. She said her testimony was very powerful in that she was, she said, the brochures that you see for college, campuses and everything, you see them all decked out. They have a comforter, they have, microwave, they have a fridge, they have all these other things. And she says, I didn't know that I had to provide that I had to buy that. I thought it came all fully furnished. And it's just, obviously they haven't had people, mentors or parents who can help them and guide them as to what is expected in college and what kind of services they need in order to be there. So, we're looking at ways that maybe we could provide that sort of support for them. I believe it was UW Stout who has a program for foster kids, and they're doing a great job there, and provided some guidance to kids who are in college. And a lot of these kids don't end up going to, Christmas or Thanksgiving. They end up spending it in their campuses, hopefully, if the campus is open. So look at how do we support foster kids. The other area is support for foster parents. The role of being a foster parent, from the testimony that we heard from foster parents, was that it's very difficult. They're seeing a lot of children who have mental health problems. They have behavior problems, and they're trying to address it and be in communication with the schools to try to mitigate a lot of those problems that they're seeing at the school. So, one of the things that they said is, they would like to see support from the department to provide more services for them, to have a better communication with the school districts on the children that they foster. And the last item that I wanted to mention was county support. So some of the counties in the state of Wisconsin, they're small, and sometimes they don't have foster homes or foster parents who can provide a home for a child. And so a lot of them are resorting to an adjoining county. Now, I know that no one, not myself, and I don't think anybody would love to see a child, who lives in one county being moved to another county. But unfortunately, if there aren't any parents, foster parents who can take care of them, they're going to have to go somewhere. And one of the things that they suggested for county support was being able to license homes in other counties. But, and we currently do this, but the licensing is child specific. So if a child needs a home and they find a home in another adjoining county, the child ends up, let's say the child ends up being reunited with their parent, then that child is moved from that home into the parent. But if there's another child who needs a home and that home is available, they can't send that child to that home because they need to be relicensed again, even though they were already licensed to have a child previously. So that's a problem that the counties have said, is a concern to them, and it would help the process for them just because they could easily put a child into a home that's available much more quickly than having to go through all the hoops of getting all the licensing. So these are just a few things that we looked at, that we heard from people who came to testify at our committee. I would say stay tuned because this is a committee that is proposing legislation hopefully before the end of the year. So stay tuned to see what some of that legislation is, and hopefully we can get some of your support on that. So with that, I will send it over back to Sam.
Well, thanks very much, Representative Rodriguez. couple nuts and bolts things before we throw it to our panel. The folders you received today have several documents inside, including today's agenda, biographies for each speaker, and a list of further resources on this topic, as well as one-pagers on the EBHPP and the Population Health Institute. And most importantly, you'll see a yellow two-sided evaluation sheet that should help you take a minute to fill out. We really aim to be as responsive as possible to the needs of our audience, and we can't do that without your feedback. And in particular, since this is the first and what we hope will be an ongoing series, your responses will be especially useful as we build out subsequent sessions to this, so please fill those out. For the social media savvy among you, feel free to tweet along at home on your chair with the hashtag EBHPP. And also you'll see there are cameras in the room from Wisconsin-I as well as a team from UW Extension. So the video and materials will all be shared with everyone in the room following the event. So I'll pass it off to our first speaker, Lonnie Berger, who's director of the Institute for Research on Poverty at UW-Madison. He's also the Vilas Distinguished Achievement Professor and PhD Program Chair at the School of Social Work. His research focuses on what drives parental behaviors and child and family well-being, and he's engaged in studies in several research areas, including the determinants of child maltreatment, associations between socioeconomic factors and children's care, and the influence of public policies on child and family well-being. Thanks very much, Dr. Berger, for being here, and take it away.
Great. Thank you so much for having me. I am really thrilled to see such a good turnout for what's a really important topic. I'm also thrilled that the approach to this and the approach to health in this is a very sort of general conceptualization of health that goes beyond just physical and mental health to really think about well-being of the population, well-being of individuals and families. So I was asked to talk about the role of the family in the sort of well-being and what it means for public policy. I'm going to make one quick plug based on Representative Rodriguez's comments. So I'm not going to talk about foster care today. My colleagues and I at IRP do a lot on the child welfare system, foster care system, so maybe we can come back and talk to you again on those topics. But I really want to commend you on this really important work that affects a lot of kids and in serious ways. So what I'm going to talk about today is more generally what's been going on with American families and a little bit honing in somewhat on Wisconsin families, what it means for health and development across the life course, and how public policy is or isn't consistent with families' experiences in the modern era. And I think the key word, the takeaway word, is going to be complexity or complex. And so what I mean by that is that that families have grown increasingly. High rates of non-marital births, I'll show you some data on that. We have high rates of parental cohabitation, parental breakup. Divorce rates are still high, although they've been declining in recent decades. We have lots of churning in families. And so we can think about two different things going on. So parental roles have changed over time in the last 4 or 5 decades, in some way around separating breadwinner and child-rearing roles. So more and more, both parents are expected to do both. But if we look at family forms, what we see increasingly is instead of 2-parent biological families or a single-parent family with a non-custodial, non-present biological parent, we see married and cohabiting step-families, right? We see families that include other adults. We see adult children moving in with parents, parents moving in with their children. We see step siblings, half siblings, full siblings. So lots of complexity, and this changes over time. So families aren't stable in the way. And so what this means is people are taking on multiple roles, both across time and at the same time. So you're at the same time a biological resident father or mother and a step parent, and maybe also a non-biological or a non-resident parent to a kid who lives somewhere else. And I'm going to show you some data on this complexity. And so this becomes really important for thinking about, when we say a parent and a child, what exactly do we mean? It turns out that now most U.S. children won't spend their entire childhood living with both of their biological parents. So the majority of kids will spend some time in a single-parent household or a household that includes a non-biological caregiver. And kids are increasingly likely to transition in and out of multiple households. I'll show you data in a minute that about over 40%, about 43% of all kids are born to unmarried parents. If you look at parents under 30, it's over 50%. Most of those children will experience family complexity and fluidity. So they'll cycle through multiple types of households and family structures, and most of them will experience multi-partner fertility on behalf of one or both of their parents. So their parents will have children with someone else. And over a third of kids will live with a parent with whom they're not biologically related at some point. So the way we think about families has changed dramatically in the way families look. And so what this means is, so this increased diversity and fluidity in family forms means that kids are exposed to a much wider variety of parental figures and potential caregivers, right? Which could have benefits, right? If you have more people devoting time, devoting care, devoting money, could be good. At the same time, it makes family functioning much more complicated. You're negotiating relationships, you're negotiating time, you're negotiating money, you're negotiating care across households and in a way that changes. Second set of points. So this complexity and fluidity are disproportionately likely among disadvantaged groups. So we can think of that as primarily among lower educated groups. This also plays out across other types of social and economic advantage. And so the most disadvantaged individuals are most likely to experience non-marital births, to have father absence, to have multi-partner fertility, and family complexity. And so this has some implications for intergenerational transmission of poverty and of inequality. Because what we're seeing is the kids who are born to families that lack social and economic resources are also most likely to experience family instability. And there's evidence that family instability is a less conducive arrangements for child well-being. We also know that as parents repartner, so as either mothers or fathers find new partners, have additional children, what you see is non-custodial parents' support for children falls off over time, right? So, and that is both commitment to time and commitment of money and child support. The difference is smallest among formal child support because we have a formal child support enforcement system. The differences are bigger among informal transfers of cash and informal time. So in turn, family complexity and fluidity are also associated with a variety of poorer outcomes. So they're associated with greater stress for parents and children, with lower parental investments, with greater poverty and income inequality, and poorer child outcomes. So what we're seeing is a selection into kids that we already might expect to struggle into family situations that are more and more difficult. Last sort of big picture point, and then I'll show you some data and things. So most of our public policies were designed in a much simpler family era. So they were designed with two parents with mutual biological children. The parents either live together or split up and one of the parents isn't there. And the way we tend to conceptualize benefits in food assistance, in tax credits, in child support, in healthcare coverage, in income and welfare, in almost every domain is around that family situation. And so what we're really talking about is one kid with multiple parents, with a set of parents, and parents don't have multiple kids, and there aren't complicated relationships. It gets much harder when kids are spending time in multiple households and with multiple parental figures. So, for example, I'll give you two quick examples. So one, child support. Child support should be the easiest, right? Turns out, take mother and father, both have two children, and consider whether they have only two children together or whether each of those two children is with a different partner, right? The mom has two kids with the same partner. She receives less for the children in child support than if she had children with two different partners. The father pays less than he would have if he had children with two different mothers. Second child, if it's with a different mother, would get less money than the first child, right? So this becomes very complicated, even in what should be the most simple of systems. Think about healthcare, right? Even if we had, so even under a mandated healthcare system, who covers the child? The married stepfather who lives with the child, the non-married biological father who doesn't live with the child. Think about this even more complicated in terms of family leave benefits, any kind of coverage if the parents aren't married, right? So this becomes very complicated for thinking about how to transfer resources. Okay, so what I'm going to do in the next roughly 12 minutes is quickly tell you how fluid and complex today's families are, what it means for what this complexity and fluidity means for family functioning, and a few considerations and implications for policy. So how complex and fluid are families? So between 1980 and now, more than a doubling in the proportion of children who are born outside of marriage, from about 21% to 43%. Big takeaway, less of a difference in single parent births that are not living with a cohabiting partner. Almost all of this difference has been a shift from married births to cohabiting births. Cohabiting couples also break up very quickly compared to married couples. So these are essentially a representative sample of children born in large cities. The solid parts of the graph are children who did not experience a family structure change among their parents by age 9. So what you see among all families, 50% of kids between birth and age 9 experienced at least one family structure change. If we look at married families, kids whose parents were married at birth, 30% of them will have experienced the family structure change, so their parents divorce by age 9, right? And then this is 1, 2, and 3 or more changes. If we look at families that were cohabiting, 70% of them will have experienced their parents break up by age 9. Another 20, 25% will have experienced their parents break up, a new partner, and then another 20% or 25% will have experienced the breakup of that partner as well by age 9. The other thing to note is cohabiting parent families and single parent families look very similar. Cohabiting parents don't look like married parents. These are Wisconsin kids. So these are all Wisconsin kids born to non-married mothers, and it's the mother's first birth. And so these are looking at these kids from birth to age 10. So at birth, 15% of them, their dads already had a child with another partner. The mother in all these cases hasn't had. By the time we get to age 10, 70% of the kids have siblings. For only 40%, do they only have full siblings or being an only child. So 60% have half siblings on their mother's side, father's side, or both. So what we're seeing is lots of fluidity. So these are a nationally representative sample of young adults, and we're looking at them at roughly 1979, 1997. And so this is the probability that by age 30, you're simultaneously have two parental roles. So you're both, this is men, a resident parent and a non-resident parent. You're both a biological parent and a step parent. And what we've seen in this 20-year period is a doubling. So by 1997, 16% of 30-year-olds are simultaneously in two fathering roles. If I showed you this for women, it's doubled as well, but it's more like 4 and 8%. And that's because mothers are much more likely to be resident and not to have non-resident kids. If I show you these trends by education and race, here's the big takeaway, right? This has increased, this complexity, these multiple roles have increased for every group except those with a bachelor's degree or more, right? And they've increased considerably for all those groups. So what does this mean for kids? And I kind of started with this. So these differences in parental investments in family functioning, so even after accounting for differences in education at birth, income at birth, and a host of other characteristics are associated with a wide range of poor outcomes on average, not for every kid, but on average for children. So from family stress and conflict, to economic investments, to test scores, to social emotional functioning, to the likelihood of participating in the labor market as adults, to the likelihood of an unintended pregnancy and non-marital birth. So, some takeaways for public policy. So first, policy really needs to now balance a much wider range of factors than it traditionally does. And what we need to think about is these multiple actors, these multiple roles within the same actors, and multiple relationships both within and across family units, right? So we need to think about biological, marital, and co-residential roles. Which do we privilege, at which points in time, and in which policies, right? We then need to think about the needs, capabilities, and well-being of mothers, fathers, and children, particularly in this context of multi-partner fertility, where parents have children with multiple partners and across households. And to make it even more complicated, right, this changes over time. So when you apply for food stamps, you may have one food unit, and 6 months later, that food unit, when you go to recertify, may have changed. And it may have changed in the first month, the third month, the fifth month, right? Public policy also has a range of economic and behavioral goals. And we really need to think about, across all of these, adequacy, affordability, and equity in both private and public transfers. So how do we do child support? How do we do food support? How do we do healthcare? Taking each of these things into account. I'm going to highlight two main areas of policy in about 3 minutes. The first being, how do we prevent family complexity? So delaying childbirth provides extensive returns in terms of education, in terms of lifetime income, in terms of outcomes for parents and for adults. The vast majority of non-marital births, almost 75% of them to women under 30, are unintended. I showed you the vast majority of these parents will break up relatively early in their children's life. So reducing unplanned pregnancy has massive implications for reducing poverty, reducing abortion, increasing time between births, increasing the birth outcomes, the prenatal care and care after kids, and reducing government expenditures. So huge implications. Essentially, we've tried 3 things to date. So we've done abstinence education. The evidence has been universally disappointing. Basically, all of the studies show that we haven't figured out how to make it work. We've tried marriage promotion. The evidence has been nearly universally discouraging. That's not to say, so look, the best path is get an education, get a job, find a relationship, get married, have a child, right? That's not to say that we shouldn't keep trying. We haven't yet designed programs that work. The third thing that we've tried is making long-acting reversible contraceptives widely and easily available to women who come to family planning services seeking contraception. The evidence is relatively early, but the evidence is quite promising. So we need some more rigorous studies, but evidence from Denver, from St. Louis is quite promising. I'll make 2 big points here, and then I'll talk about serving families. So big points is that families should both address the reality of family complexity, and it's unrealistic to focus on current couples and their joint children. We have to think about their larger family context and promote healthy relationships among that wider set of actors. And then secondly, for non-custodial parents, so policy should really recognize that child support, employment, and father involvement really go hand in hand, right? And these are really complements and not substitutes. So one thing that I would argue is that we should think about providing parallel packages of supports, benefits, and tax credits that are available to custodial parents, to non-custodial parents. So this would include, so most non-custodial parents in policy are approached as non-parents, right? So they're adults without dependents because their dependents don't live with them. And so we could think about work supports and benefits that give partial credit for non-resident children conditional on paying child support. And we could withhold child support from tax credits, from other types of benefits, right? I think it is crucial that we do have a strong child support enforcement system, but we should also recognize that what we often do for custodial parents is help them to connect to employment and help them to increase their wages in employment. We have a W-2 system that does that. We don't have a parallel set of programs for non-custodial parents. And so that we should think about, if we expect non-custodial parents to pay child support, which we should do, how can we promote that through the tax system and through work supports? And then the criminal justice system is just looms hugely over this entire population. And it's really important to think about these reforms in the context of particularly men with criminal justice histories. So thank you very much. I'm happy to address more details in the Q&A.
Well, there's no questions from the audience. I guess we'll move right along to our next speaker. Ms. Green-Harris is the director of the newly created Center for Community Engagement and Health Partnerships in Milwaukee, which works to advance research in the African-American community in a culturally inclusive manner. She's also the director of the Milwaukee Regional Office of the Wisconsin Alzheimer's Institute, where she oversees the health equity pillar for that group. Is also the director of the Life Course Initiative for Healthy Families, a community-driven initiative funded by the Wisconsin Partnership Program, which develops and implements strategies to reduce disparities in birth outcomes for African Americans in Wisconsin. I know there's some staff from the Life Collaboratives in the room today. I'd like to recognize Pamela Smith, who's here today. Thank you for joining us. I'm extremely excited to have Ms. Green-Harris here today, so take it away.
Thank you. Good morning, everyone. Okay, let's work on this. Let's work on this. It's almost noon. You guys have had plenty of coffee. So good morning. And I want to thank you for this opportunity to actually talk a little bit about what the work is that we're doing on the other half of health and the social determinants of health. So I always start out my presentations by letting you know that there is science in the slides, but it's really the heart of the passion, and that our jobs really focus on making sure that the people in the communities are reflective of the work that needs to be accomplished. So you will see some stats and you will see some data, but the majority of my conversation for the next 20 minutes or shorter or so, we'll be talking about how programs are essential to discussing these issues around dementia and, quite frankly, infant mortality, which we know, in all honesty, will not be resolved in the next 2 to 3, 10 years. But we do know we can begin to start having programs that are affecting change over incremental time, and that's what I'm going to talk about today. So I want to put you in the context and the framework of understanding, and this will come from a lens that is relative to the communities we serve. So our population is primarily focused in the African American community, so the social determinants of health are absolutely relative to the conversation. And so I do want to thank my colleague here for such a great platform and presentation, and of course Representative for setting the platform for what we're doing and what we're discussing today. The work that you're doing with the kids and the families is absolutely wonderful on both fronts. And so you've answered a lot of my slides, so I'll skip through some of them. Is that all right with everybody? Yeah, say amen. I mean, say yes. It's all good. And so I'm going to get started. Basically, what we see here on this first slide is that social determinants, basically, as we've already talked about, are essential and really do matter to our health. And this one actually talks a little bit about education, as my colleague has just discussed. Education is critical to us addressing the issues around infant mortality, around Alzheimer's disease, because we know that what we do at the beginning of life actually impacts the end of life. There's not a way where we can actually just talk about if we have healthy babies that we can ignore the end of life trajectory. It doesn't work that way. It's all about life course. And what we do at the onset will significantly impact the outcomes, and that's exactly what I'm going to share with you today. The other thing we also know is that with better education, we also have higher economic attainment, along with better housing, stability, and again, we will show you later in stats how this actually will increase our brain health. Is what research is showing. So obviously, mom's education increases a baby's chance of survival. And then I want to go and just talk about adverse birth outcomes in African American women. Obviously, there's a social context behind that. But the other piece about that is that when we look at African Americans having the highest rate of mortality and adverse birth outcomes among all ethnic and racial groups, that's really critical, because while I'm telling you education is important, I also want to let you know, for those of you who don't know, and I know there's many folks who already are doing the data collection around this, education alone is not something that we can depend upon. It's all of the social determinants, because even as an African American woman with a post-education, I still have higher risk for infant mortality or loss of a child. So it's not just entangled in the let's get a better education system. That's just one of the pieces of the pie. And so that's why we have to talk about the data is very critical to the work we do, but equally as important is what do we do for those social constructs to begin to address this issue from the social determinants and the social side of health. Does that make sense, everybody? Mm-hmm. So And by the way, I just have to put the disclaimer: 20 minutes is like 5 minutes to me. So you just have to work with it, sister. Uh, but I want to be clear when we talk about here the racial disparities. What I want to emphasize here is lifelong stress. This is going to talk to you about why is stress important. Lifelong stress. That fourth bullet up there says stress and racism are constant factors in African American women's lives and are inseparable from our pregnancy or their pregnancy experiences. So again, beyond education, we have to understand that stress across our lifespan does actually impact our health and our birth outcomes as well. And again, I'll show you in the same with dementia as we get to that slide. So basically, I want to talk a little bit about the Life Course Initiative. The Life Course Initiative for Healthy Families is a regional collaborative effort to support African American women and their families to have healthy birth outcomes. It was initiated in 2009 under the Wisconsin Partnerships, and the goal is to address issues on big or small P policy, systems, environmental changes to address the root causes of why these disparities exist. And that has been interesting, and we have actually understood, if you look at the chart that we're showing, counseling and education, when you look at it, has probably the smallest impact but you have to go down to those socioeconomic factors, which again, we look at oftentimes clinical reasons why women are having birth disparities, or we start talking once a woman is pregnant. We have to go back and actually look at all of those risk factors, those socioeconomic factors from the very beginning of that life course, not just at the point where a woman is actually becoming pregnant. So it's a Wisconsin issue. We know that Wisconsin has one of the worst black-white disparities in infant mortalities in the United States. We're working towards making sure that that is not the case, but it is right now, and most of you know that in this room. And we also know the Life Course was initiated to address the disparities that is among African American women. Clearly, the chart shows that there is a racial issue in this state. The total, of course, of infant mortality is 5.9 overall, but 13.9% of African Americans experience disparate birth outcomes. So what is our approach? Basically, infant and child well-being is a reflection of access to health care and health information, as well as social, economic, and physical environment. So we know that basically we have to address the issue. Again, improving health is more than just looking at health systems. It is actually addressing the individual needs, but also the systemic drivers and forces behind why poor health is actually occurring in our community. So we talked about the life course approach, and I'm going to talk about it real briefly for you. Again, these are regional efforts that we're going to do, but we're also doing the efforts at a grassroots level. I want to talk real briefly that the life course approach talks about using community. It talks about relationships, building the strength and the assets of the community, and then it talks about looking at what policy systems and environmental changes do we need to take. We know it's a local issue, but most of these, if you can probably see neighborhood conditions, discrimination, unemployment, and on and so forth, basically are in individual communities, but we know they mainstream across several segments of all populations and all of the neighborhoods that we're actually looking at. For healthy babies to be born and stay healthy, we have to focus on the moms, the families, and we have to have access to quality health care. Social and economic environments actually promote positive health outcomes for these moms, babies, and families. And so our local efforts, basically we have life collaboratives. We have a collaborative model that we are actually putting into place. It's a coalition action theory and collaborative action theory that we're putting into place. And we have identified currently 3 communities, and they are Racine, Kenosha, and of course, Milwaukee. And the goal, of course, is to engage diverse stakeholders and groups in developing and implementing multi-level solutions to dealing with this issue. And Life Collaborative members include residents, leadership from nonprofit healthcare, business, public sector, and faith organizations. Again, going across systems so that we can actually address this issue in a collective manner. So what are the local efforts? And as Sam has indicated, Pam is here from Ms. Pam Smith from the Kenosha Collaborative. Each of the collaboratives has an action agenda of local policy systems and environmental changes and policies. And why is that important that each community has their own? It's relative because while we can talk about the systemic issues that cross unilaterally across all communities, there are some unique differences and there are some clear-cut priorities for each community. So what you'll see is that Kenosha focuses on mental health and housing. Milwaukee Life Collaborative focuses on reducing prematurity, and the Racine Collaborative works on breastfeeding and teen health. Now, we also know that because we have these issues at the local level, it doesn't disconnect us from what's happening regionally. And so we know there are some common threads across what happens regionally. And quite frankly, more than 80% of the babies born to African Americans are in Kenosha, Milwaukee, and Racine counties. And because we have the worst disparity in the country, we know that we have to connect and see what can we do to actually garner the reduction in these communities together. And so what we have actually created is an opportunity for us to come together in a regional work group setting that crosses all of the continuums of the community to have a common mission as well. It is our goal not to just, again, it is our goal to reduce the disparities locally, but regionally and statewide. And the only way to do that is to come together. So we have a universal depression screening for African American during perinatal period. We know that, again, depression reigns in the community. We understand that it's still some stigma related to that, but we want to begin to address that. So over the past year, as a regional working group, we've worked together to identify this regional priority. The members have developed a working understanding of this priority. And we're setting to actually develop some specific outcomes for 2019. Our strategies need to be within a scope that we can, that's either existing or something that we can actually secure so that we can make sure we're actually affecting the policy systems and environmental change. We also know that the priorities, by the way, were actually identified by the collaboratives based on what we have come together using data to support where we're going in this initiative. We also have, by the framework we're going to use is to lead or co-create a stigma reduction campaign around depression that we know is facing our community. We're going to support to co-create provider education about stigma and then monitor. We'll advocate for quality improvement project to increase maternal depression and screening and address the barriers that women are actually acknowledging to actually getting screened, but also to address the barriers that providers are suggesting around screening themselves. And so we're really trying to make this an effort that addresses all of the stakeholders so that we're not just doing one piece of the pie and not serving the whole dish. The question for the collaboratives are there concerns about adapting an action agenda, and how do we do that? And we're going to focus on that. While I talk about the differences in community, and my colleague here, thank you so much, Lenny, for talking about fathers. One of the common themes that we've come across, and so I talked to you about the initiatives at the local level, right? Each of them have different focuses, but we know it's not, we can't just focus on moms and babies. We've got to be inclusive of the entire family. And I'm really proud of the initiatives that have come out of each of the collaboratives. And one common thread across that initiative is the inclusion of fathers. Fathers play a very integral role in our children's lives. And so in Milwaukee, we have a barbershop sessions to elevate dialogue. Kenosha developed a fatherhood program that adds involved fathers to the WIC program. And then Racine focuses on building capacity to support breastfeeding for moms through fathers, which is also, all of these initiatives are designed specifically to engage the father in parental activities, along with making sure that the community sees the dad's involvement as critical to how we move these agendas on addressing these disparities. And so some of the opportunities that we believe are, obviously, again, we've addressed those, so I won't hound on them, but basically advocating for policies to improve the overall social and economic health and well-being of the population across the lifespan. That includes poverty reduction, earned income tax credit, right? Housing. We would love to see something that addresses the issue around eviction of pregnant moms. so that when a mom is pregnant, we make sure that they have stable residence. We just talked about the issue of stability. We know that has to be important. Also, another critical piece is improving access to quality care. Just as we've talked about depression as something that we want to address, we also need to make sure that there are actually competent providers who can address the issues that these moms are facing, along with addressing the issue of stigma that is a huge factor and why some moms would never even talk about depression and or poor treatment once we do enter into systems. So we really need to address some of the systemic challenges that we're facing, along with other issues such as childcare, work support, and of course our favorite, paid time off for moms. So I'm going to briefly, in my next, I think I got about 7 minutes, talk a little bit about Alzheimer's disease. And I will tie these two together so that we can understand from the beginning of life perspective to the end. So Alzheimer's disease, we know that in this country, Alzheimer's disease is the 6th leading cause of death in the United States. We also know that every 66 seconds someone is developing this disease, and we also know that baby boomers continue to age, and these numbers will not go down. The yearly out-of-pocket costs for services and programs can range anywhere from $3,500 to $20,000. That is really relative when we're talking again about healthcare, when we're talking about systems, structures, and support for what happens with this dreadful disease. Now, the other key factor we need to understand is that it's going to cost us $200 billion in healthcare to continue to care for families with Alzheimer's disease. So we have to come up with creative solutions. And I want to do here a commercial break to stop and thank the Wisconsin legislators who have put forth the bill to start addressing Alzheimer's disease recent as October 20th, 2017. We are looking forward to legislators, and we certainly have been doing our calls to make sure that we support that, because we know family caregivers are definitely in need of more supportive services, and we also know we need to address some of the systemic challenges for families facing Alzheimer's right now. So African Americans tend to be at greater risk for Alzheimer's disease, as with other social determinants of health. And we'll talk a little bit about that. Basically, roughly double African Americans are more likely to get some form of dementia in a lifetime. Now, the key factor here is that we know it's not necessarily genetic, so it has to do with some of these social determinants that we're talking about. And even as the research shows, basically what we are finding is that when we're looking at what will help folks of color, it's basically coming out to be some of the social constructs that we know we're facing. So we try to address this issue with our programs and services, and we initially thought the challenge was that folks just couldn't access care. So we created a model of a memory clinic, a diagnostic memory clinic in Milwaukee that focused specifically on African Americans at Milwaukee Health Services. This was funded through the Wisconsin Partnership, which we were excited about. The goal was to get folks to the clinic to get a diagnosis, because when we did our research in the community said to us, "You guys are so smart. You can tell us we have Alzheimer's disease, but how do we get a diagnosis?" And so we went out and helped develop this diagnostic clinic. And what we did is we did something a little unique. And we actually put the patient in the center, at the center of the care. We worked with them to get a diagnosis from a provider, but we didn't stop there. We actually went back to provide care support, not only to the person living with the disease, but that care provider. We connected them with services such as the Alzheimer's Association, Interfaith for older adults, so they could get respite care. We connected them with the Aging Disability Resource Center so that they would then have services that could connect them to care. And we began to basically get an understanding that this was important. The first step was to get a diagnosis. The second step was to actually educate providers on how to diagnose. What we do know, according to the Alzheimer's Association, is that only 41% of the doctors are providing diagnoses for their patients who they know have Alzheimer's disease. And that's critical, because what we also understand is that people want to know if they have dementia. Why? So we can plan. Why? So our families can actually understand what this caregiver journey will look like. There's been a recent work by Dr. Amy Kine at the UW. We had to go further. The socioeconomic contextual understanding of disadvantaged neighborhoods. Again, back to what we've all been talking about. The fact of the matter is that we can get a clinical diagnosis of dementia, we can provide social support, or we can provide services, but the fact of the matter is that we know that neighborhood disadvantage early in life is going to play a role in those outcomes. And so this is an early study, but we have found, and what is being found is that disproportionately higher levels of low socioeconomic status and disadvantaged neighborhoods leads to higher proponents of folks getting Alzheimer's disease. Now, that's critical and crucial because what do we do in this context and how do we actually address these issues in the community? Because we also know, the other report says stress is significant to these communities. Again, many of our research studies focus on genetic testing. And what are the genes showing us? The fact of the matter, in African American communities and other communities of color, our Hispanic neighbors, along with our natives, we're finding it to be more social constructs, more so than it is necessarily only our genetic makeups, which is going to be crucial to what we know we have to do. So I just wanted to give you guys again for the risk factors, and for those of you who wanted to see it in black and white, African Americans basically, and these are RAP participants, Wisconsin Registry for Alzheimer's Prevention, demonstrate higher blood pressure, diabetes, and obesity than our white counterparts, hands down. Again, social determinants of health is clearly in here. So what is the burden of Alzheimer's disease in communities of color? Let me talk briefly, and then I'm going to come to my conclusion. More likely than not, African American caregivers will provide more hours of care, higher intensity of care, and use less access to supportive services and to not access services. We also know that the bottom bullet says even though African American caregivers are caring for severe elders, basically they are less likely to place them in nursing homes, which means, again, the high level of caregiver burden and stress. And we also know that while we're caregiving for our loved one with this critical illness, we also are caregiving for other people in addition to this frail elder. We have minors, grandchildren, and other family members. We also know that our children, our caregivers, are more likely to be African American women of working age, 44 to 65, unmarried with less formal education, fewer financial resources. The data also shows, again, less likely that we will be able to sustain our income over time. There's more loss in these communities. So, but the good news is that caregivers of African American communities find it rewarding to give care, more so than our white counterparts. And that is, reasons include basically normative of the experience, right? So it's my duty to caregive, right? It is something that gives me actual purpose. And then our spiritual guidance also plays a role in why we have much more rewarding experiences in caregiving. However, I want to give the clear message that it does not negate that we actually experience worse health outcomes, even though we have greater knowledge in saying that we are experiencing a better caregiving process. So what have we done? We've actually tried to listen to the caregivers, and the caregivers have said, again, we understand we have to be on this journey. We looked at Dr. Mary Middleman's work. She actually invited us to come to New York. She had a course that provided positive experience for caregivers. It started out as a respite program for caregivers who were caring for folks with Alzheimer's disease. One of the stats I did not share is that caregivers actually who care for people with Alzheimer's disease tend to have less poor health than those of just other types of health care. So our caregivers asked us for programs that could support families. So we have what we call the Amazing Grace Chorus Family Support Program. It's culturally tailored, based on evidence. It is stigma reduction. It gives caregiver support, educational presentations and resources. We bring the resources to the family, but we also provide social support and peer learning for the family members or the caring parents, as well as those who are experiencing the disease, along with the caregiver and extended families. Now, one of the biggest and best parts about this mission is that it's no cost to the family, and it's 14 weeks of performance that you will get to see. The one thing the caregivers, and I'm going to let you go, Sam, in 2 seconds. Sam's going to share something briefly, but I just want to say this. What the caregivers and what the folks who experience this course have said, it reduces their caregiver stress. It improves the mood of both the caregiver and the person living with. It improves memory recall, self-confidence, and the like. So we have just a snippet of what the course
This was
has
working at
done.
9:45 this morning, so cross your fingers, everybody.
So it's good to see everybody here today. I hope you've had a wonderful, wonderful, wonderful week.
One of the things we know is that when we bring programs into communities of colors, it's very important that the community actually lead the program, if you will.
We're going to do the vocal warm-up.
We wanted to bring them into an experience where they could actually enjoy the process and learn from the process and help us understand if this is actually the way to go.
The first session we had was interesting. A woman, she stood up and said, "It's about time somebody's doing something for us." That says a lot.
As the folks sing, we see them light up. We see them actually engage. And we hear stories from the caregivers saying, "My mom is singing at home. My dad is doing new words."
I see self-confidence in many of them from when we first started. What I'm hearing from the caregivers with their loved ones, they see how they're more verbal. They see them singing the songs at home. Other caregivers feel the support.
The thought of the choir was first presented to us, I really kind of hesitated, but certainly I am super glad that we were willing to step out and try it, and then it's become way more than I would have thought. I think it's helping her with her memory, and that, of course, makes us feel good.
It brings back to memory things that occurred in my life a long time ago, and I have a lot of fun with it with my children.
It lifts the spirit, and I'm so glad that it helps my wife a lot. She can be pretty down when we leave the house, but when we get here and start singing, and especially if I lead a song, she joins in and helps me without even being asked, you know. So it's very helpful.
I feel free when I sing. I feel happy.
Singing it and then listening to others sing in the group is uplifting. We can't wait to get here for practice, and when we leave, we are feeling good. You know, it keeps us going all during the week.
And after you've been here for a while, you actually feel the therapy and you feel the remembrance coming back. You know, it helps you with your mind, body, and soul. It really do.
It's a family thing, you know, and they look forward to coming now. It's rain, sleet, or snow. And some of them come aching, but when they come here, it seems like the aches and the pains all go away.
So we know that providing support to our families is critical to the work that we do, and we are honored to actually do this work. I'm going to end with just two thoughts. Common threads, again, Life Course Initiative, Life Course as a whole. We know the common threads are lower income. We know adverse health outcomes, disadvantaged neighborhoods, but we also know lack of access, but we know there are also modifiable risk factors and programs that we can do to actually integrate ourselves so that we can build programs like this so that our families, while we may not be able to cure Alzheimer's disease, while we may not be able to end the adverse birth outcomes tomorrow, we can do things intermediately to make sure we're addressing these issues. So I want to thank you and for allowing me to have this presence in this moment, and I will answer any questions. Thank you.
Thanks so much, Gina, for that presentation. Any questions from the audience for either of our panelists at this point?
Hi guys, thanks so much for your presentations today. Lonnie, a question for you. As you see increased family complexity, how does that impact parental engagement, such as like biological mom has a new partner, new husband, whatever, is biological dad as engaged, or does that impact engagement as the family structure becomes more complex?
So once again, it's complicated. So the general pattern is that as parents repartner, so if you think about a particular kid, the parents are split up, the less involved the non-resident parent, the more likely the resident parent is to repartner to begin with. But even accounting for that, once they repartner, you see a decrease in involvement. That's true regardless of which parent repartners. And then you see an additional decrease if either of the parents have additional kids. You know, as I said at the beginning, so where you see much less decreases in formal child support payment, right? Because there are consequences. You see a bigger fall off in visitation, in spending time together, and in informal support. The other thing that's sort of interesting is for moms repartnering itself. So when moms repartner and generally, you know, start living with a new boyfriend or husband, their material resources increase, right? They have less material hardship. There are improvements in their well-being, so decreased depression and stress and things like that. I've done some recent research looking at more disadvantaged kids. It turns out that the stepdads, particularly if they marry, so less so if they just cohabit, are quite engaged with the kids at equal levels, and in some cases more so than kids whose dads stayed with them, than married biological dads who have always lived with their kids. The unfortunate piece is that the relationships are no more likely to last despite these good, some of these good pieces. So it's well known that second relationships or repartnerings are less stable than first partnerings, and it doesn't seem that those positive pieces do a lot to change that.
Thank you both for those excellent presentations. I know Dr. Berger presented a pretty clear policy recommendation around supporting non-custodial parents with their efforts toward employment and other. And I'm interested in Ms. Green-Harris, and what you presented, I think, a pretty clear picture that we need to be supporting these efforts toward improvement in socioeconomic status and also some respite programs in the communities. I'm interested in if you have any, like if you have one ask of this policy audience that we have here today, what would that be?
Sure. So one specific ask, I think, is clearly around developing culturally tailored programs that support the caregivers. While we have put money into caregiver dollars for respite, we have not necessarily designed caregiver programs that are evidence-based, that are built by the community. So what I would suggest is that even as we're funneling money to agencies, that we require them to actually be community-based and programs that we know are sustainable, but also are built by that community need and that lead from the community. So for instance, the chorus is something that is affordable. It's something that leads positive experience. It's one type of evidence-based program to reduce caregiver burden. It's not our traditional go to a support group class, but it is something that builds camaraderie. And we also have noticed that, again, looking at the data, that the caregiver burden stress has been reduced to those kinds of things. So I would suggest really being innovative. Another suggestion that I would also encourage folks to think about, policymakers, and that is actually creating across the board requirements for what is dementia capable and dementia standards in facilities. We know for sure a lot of our caregivers express that they put their loved ones into care facilities who say they're dementia capable, but when they get there and have challenges because of the disease and the progression, they tend to not be able to care for them in an appropriate manner. So actually mandating and developing some minimum standards around what is dementia care, effective and adequate dementia care. So those standards would be something else I think we could look and ask policymakers to do.
Thank you. Can I actually follow up for a moment on that? I know we're almost out of time, but on the other end, with regard to the respite and caregiver, when I did a little bit of work on a birth outcomes program that was addressing Milwaukee, Racine, Kenosha at the time, and this was not too long ago, it seemed to me that there wasn't a parent respite program in Racine and Kenosha like there was in Milwaukee, unless it was for children with special health care needs, and that seemed to be a gap. Does that still exist as a challenge for young single parents who need some respite, who are overwhelmed with their circumstances?
It is my understanding, and I can certainly talk to Pam around that issue and our team in the life course around that issue. But I would venture to say that the answer would probably be yes, and that is based on the fact that young moms and what we tend to look at in communities is, again, special needs, and not necessarily looking at those who are just general challenged,
Right.
exactly, in caregiving. So, but I can further and get that information to you in more detail.
Thank you.
And with that, we'll probably have to call at the end. So final thanks to Dr. Berger and Ms. Green-Harris. Thanks to Representative Rodriguez, who had to step out for other commitments, and to all the folks here in the audience, including legislative staff. Today's discussion strengthens the ongoing dialogue between the campus and the community, and is impossible without all of your support. So thank you, and hope to see you back here real soon.